Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. Do you remember the book A Very Hungry Caterpillar by Eric Carle? I do. I read it with my 2-year-old last night, and as you may recall, the caterpillar's transformation starts slowly. On the first day, Monday, he eats just one apple. On the second day, just 2 pears. But the caterpillar's hunger and its growth builds and builds on itself until Saturday. Watch out, party time. It eats chocolate cake, ice cream, salami, a pickle. Of course, the caterpillar has a stomach ache afterward, but it's also clear that it's just about ready to take the final step in its transformation. And now I hope you'll forgive the extended analogy, but I couldn't help but think about Medicare's transformation as I reread this book for the 1,000th time yesterday, and not just because I was about to have this conversation today. Medicare has just turned 60, and over that time, it has grown and changed, and that change has been fairly incremental and steady. But lately, it seems that the pace and the tone of that change has gotten a lot more chaotic. We're talking about Swiss cheese and lollipop levels of chaos. And it has me wondering, what's going to happen next? Is it time to reset and eat a green leaf? Or are we on the cusp of an even more dramatic transformation? That, at least the implications of that very tortured metaphor for Medicare, is the subject of today's Health Podyssey. I'm here today with Stephen M. Lieberman, a non-resident senior fellow at the USC Schaefer Center for Health Policy and Economics. Stephen has served over the years in senior roles at the Congressional Budget Office, Office of Management and Budget, and the National Governors Association. Together with his co-author Rick Mays, he has a new health affairs article recently published ahead of print titled, quote, Inside the Meteoric Rise of Medicare Advantage. I can't wait to learn all about their take on all this change. Stephen M. Lieberman, welcome to a Health Podyssey.
Thank you, Rob, very much. And as somebody who has 4 young grandchildren, I am very familiar with the Hungry Caterpillar. Would not have thought of it as an opening introduction, but it really does fit quite well.
All right. Well, I'm at that moment where I just can't avoid it. I'm glad you appreciated it as well. Maybe we can start with a little bit of the prehistory about Medicare and how it's changed. Let's start with the Tax Equity and Fiscal Responsibility Act of 1982. I feel like 40 years or so is about enough time in the past to kind of get us started. How did that pave the way for Medicare Advantage? And what are maybe some of the other notable trends that were taking place in the insurance markets in the 80s and 90s?
Great question. Let me take it in 2 parts. What TEFRA was primarily a tax bill, but it had 2 fundamental changes for Medicare. One was quite direct, the creation of the Medicare Risk Program, which was the ability of HMOs to contract on a capitated basis with Medicare. Up until this point, we only had HMOs able to engage on a cost basis, and that was very limited. The second change was more indirect, and it was the creation of what are called the Section 222 and 223 limits, which were limits on the costs that would be reimbursed for hospitals and physicians. And what had happened in the 70s up through the early 80s was enormous growth in the cost of healthcare, and particularly Medicare. And so the 222 limit, so-called, scared the bejesus out of the hospital industry because they would have significantly reduced reimbursement. And so they led in the next year, in 1983, in the Social Security amendments of 1983, to the creation of the Inpatient Prospective Payment System, or the DRG system. And the phrase at the time was anything but TEFRA, to avoid those cost limits. And to go to the second part of your question, which was what were the other significant trends, the first thing is the effect of the inpatient prospective payment system was to radically transform incentives and start to get control of hospital costs. Instead of reimbursing hospitals for their allowable costs, they were paid on a fixed payment basis. And over the next roughly 10 or 12 years, almost all of Medicare payment systems, with the exception of the physician system, shifted to some form of prospective payment. What happened in the late 1980s was Medicare went from a very peculiar system to having the Medicare fee schedule created, which took a number of years. There were also some efforts to get control over the cost of physician services, because it turns out that controlling price did not control costs because of the increases in the volume and intensity of services. So just to finish the answer, I think it's fair to characterize the early part of the 1980s and the 1990s with 3 or 4 trends. First was the continuing massive growth of healthcare as a share of GDP, along with the cost of Medicare. That drove lots of efforts to constrain cost. And so from a fee-for-service perspective, the 2 most important trends were the shift from cost reimbursement to prospective payment, and for the physicians to the creation of the physician fee schedule. The other trend that happened was the enormous growth of managed care. And while HMO care did not grow that enormously, preferred provider organizations and other forms of managed care grew enormously. So in 1988, in the employer sector, literally 78%, I believe, of employer insurance was classic indemnity insurance, which is what traditional Medicare is. By 2005, we were down to, I think it's in the paper, I think it's around 5%. So we basically saw the elimination of traditional indemnity insurance. What that gave rise to was a backlash against managed care, particularly in the mid to late 1990s.
Got it. Okay, so just like a ton of transformation, public opinion sort of having a role there, but also just sort of the freight train of the kind of bureaucratic policies leading to health systems providers kind of responding to those incentives. Let's now move ahead to the creation of Medicare Advantage. I believe that came through the Balanced Budget Act of 1997. Can you sort of put us in that moment there? What were you doing at the time? And I'm curious if there was like an explicit argument in favor of the creation of a program like Medicare Advantage, or was it more of sort of just like the next step in this inevitable process of transformation?
So let me start with a slight technical correction. The Balanced Budget Act of 1997 created what was renamed the so-called Medicare Risk Program to become Medicare Plus Choice. The Medicare Modernization Act in 2003 changed the name to Medicare Advantage. I would argue that while there were important changes in each of those statutes, the name change was not the important part of it.
Got it. Okay, fair enough.
So what I was doing, I had been the person at the Office of Management and Budget, this career person in charge of Medicare and Medicaid, and then I got kicked upstairs and became a career assistant director at OMB, and I left in early 92 and went out west, primarily to Arizona and then California, to run managed care, because I had the perception that the interesting work was going to be at the delivery system level, no longer at the federal level. So in 95, 96, 97, I was primarily involved in helping build Medicare, what are now called Medicare Advantage programs in different parts of the country. What we had in the mid-90s was 12% of the Medicare population in 1997 was enrolled in Medicare Plus Choice, now Medicare Advantage. I'm just going to call it MA without worrying about the name changes.
All right, let it be stipulated.
Thank you. What happened was those benefits were quite disproportionately concentrated in a few states that had extensive managed care. So places like California and Arizona, which had very high levels of HMO penetration, became the places where there was lots of Medicare Advantage enrollment. And what happened was people like Senator Grassley from Iowa were very jealous of the fact that his constituents couldn't get access to the extra benefits that were available in Medicare Advantage plans. So the BBA, so just to finish up, one of the things I did in 1996 and 1997 was to work with two organizations to create what were called provider-sponsored organizations as demonstrations to let non-HMOs participate. That actually was a provision in the BBA, in the Balanced Budget Act. As far as I know, I'm not sure there are any provider-sponsored organizations that are MA organizations. But at any rate, to get back to what was driving it, the problem was the misallocation, the unequal distribution of Medicare Advantage throughout the country. There were about 200 counties out of the over 3,000 counties in the country where there was significant Medicare Advantage penetration. And as we point out in the paper, in 3 states, a very large share of the overall population of enrollees. So that was the problem. Part of the solution was to allow organizations other than HMOs to participate, and there was a change in how payments were made.
Got it. I think today we sort of envision there being a dynamic between traditional Medicare and Medicare Advantage as kind of a competitive universe. There's this sort of heavyweight matchup between these two enormous entities sort of vying for the same pool of beneficiaries. How was that relationship envisioned as this program came about in the late 90s and early 2000s?
So I don't think anyone at the time had any perception that Medicare Advantage would grow the way it has. And to underscore that point, in 1997, as I mentioned, I believe 12% of the Medicare population was in Medicare Advantage. Both the number and the percent actually fell after the BBA was enacted, in part because the Balanced Budget Act of 97 had significant cuts to Medicare, traditional Medicare fee-for-service, which lowered Medicare Advantage payment rates. And in fact, in that period, it's the only time that Medicare costs actually fell from one year to the next, after which, obviously, the growth trend has returned. So I think the answer is people did not envision a great, rush to Medicare Advantage. People didn't envision that Medicare Advantage benefits would be basically 20% greater than the benefits that were available in traditional Medicare.
Got it. Okay. And in your paper, you describe this rapid growth. The title calls it a meteoric rise. Obviously, we know now that more than 50% of beneficiaries are in Medicare Advantage programs compared to traditional Medicare, and a big amount of that growth has come in recent years. Can you say a little bit about what exactly is going on? What's driving that growth today? And what do we know for sure? What do we kind of suspect? What's your hunch? And how do you kind of put all that together into the bigger puzzle?
I'll try to be clear about what's factual and what's my assumptions. What's factual, and I think MedPAC has done an extraordinarily good job, along with some other researchers, to highlight the fact that there are three ways in which Medicare Advantage benefits are significantly greater, and the payments for an individual who's enrolled in Medicare Advantage are significantly greater than what that person would have cost in traditional Medicare.
And just to clarify, when you say payments, you're saying the government's payments to the insurance company and compared to what the government would pay to cover a traditional Medicare beneficiary.
Precisely. And so the biggest source of that, actually, and it's changed in the last couple of years, is what's called favorable selection. And so, without getting too wonky about it, Medicare adjusts the capitation, the fixed monthly amounts that it pays to insurers, based on their health status and some other demographic characteristics. The problem with that system, so obviously, if you have somebody who is expected to have very high costs, you pay them much more than somebody who's expected to have very low costs. The problem with that is, and this to me is one of the most fascinating things, is if you were to rank traditional Medicare beneficiaries from the least expensive to the most expensive and put them into quintiles, 20% groupings, the top quintile accounts for about 3/4 of cost. The bottom quintile accounts for less than 1% of cost. An extremely skewed distribution. And to get slightly wonky, the mean is 3 or 3.5 times the median.
Wow.
And so that distribution, when you just look at all traditional Medicare beneficiaries without risk adjustment, one of the pieces of research that I did with my colleague Paul Ginsberg at Sam Valdez is that distribution is virtually identical when you look only at beneficiaries that have the identical risk score. So the problem is that even though you're using the average to adjust payments, the people who move into Medicare Advantage are significantly below average. In fact, our research has shown on average they have about half the expected cost of the average person. That results in about 10 percentage points, according to MedPAC, of overpayment. The second major source of overpayment is what's called coding intensity, or known as upcoding. Because in fee-for-service, providers get paid for services. They don't get paid based on diagnoses. Slight exception to that for hospital admissions,
Sure.
But let's keep this general. In contrast, Medicare Advantage companies get paid on diagnoses, which is what drives the risk adjustment system. So there's a recent paper in the Journal of the American Medical Association by Rick Kronig and his colleagues, which compared coding intensity in fee-for-service traditional Medicare to Medicare Advantage and by specific Medicare Advantage organizations. And what that analysis, which builds on a lot of other work, shows is that the Medicare Advantage coding is much greater than in fee-for-service, and that there's a real issue where two of the largest Medicare Advantage organizations are the most aggressive upcoders, and which can generate up to 50% more payment, which creates two issues. And I'll make this real quick. One is it obviously increases the payments to Medicare Advantage plans.
Incentive to find more intense code.
Right. So between favorable selection and upcoding, that results in sort of $84 billion in 2025, according to MedPAC, of higher payment, about a 20% overpayment. And there's one other source that I'll come to in a moment. And that is the biggest reason for why Medicare Advantage benefits are because Medicare Advantage organizations are getting paid over $2,200 per beneficiary, more than traditional Medicare people would cost. That allows them to finance additional benefits. The second problem, and I just want to highlight, is about half the Medicare Advantage organizations, again, according to MedPAC, upcode by less than an adjustment that is used to offset a portion of the upcoding that applies to all payments. Those half the organizations only enroll about 15% of Medicare Advantage beneficiaries. The other half of Medicare Advantage organizations that enroll about 85% of beneficiaries upcode significantly. And the problem is that the more you upcode, the more revenue you get. So it creates a very unequal playing field, not just between Medicare Advantage and traditional Medicare, but among Medicare Advantage organizations. The third source, and it's not worth going into, is the star ratings, which is $15 billion, and not technically an overpayment because it's statutory.
That's right. So a lot of factors there that have sort of incentivized the growth of Medicare Advantage. Some have argued that there's really so much variation in MA plans, where some are basically just paying their providers at a fee-for-service basis, while others have implemented their own alternative payment models sort of under the MA hood there, that it can be very hard to compare plan to plan, and that it can be very hard as well to make generalizations about the quality of care that Medicare Advantage provides writ large, or the outcomes. And so I'm wondering if you have thoughts on, are we able to make some of those judgments and comparisons about quality and how MA has changed the care that people receive writ large?
It's a great question, and unfortunately, the differentiation among the plans makes it hard to have a broad answer other than the generalization that on average, Medicare Advantage plans have not been shown to have improved quality compared to traditional Medicare. One of the confounding issues is it's hard to compare beneficiaries because of the degree of upcoding. So not clear that you're comparing comparable things. There are organizations that, I think one of the things it's fair to say is that most Medicare Advantage organizations emphasize primary care. And most Medicare Advantage organizations also use a variety of techniques to manage utilization, such as prior authorization. The problem is that some organizations do that well and appropriately. Some do it arguably as a way to control cost more than clinical quality. So it's just an example of why it is very hard to generalize.
Okay. Well, against that backdrop, can you say a little bit about maybe some areas that are perhaps ripe for policy reform in relation to MA? Are we just going to continue down this path of rapid growth, or do you see any particular problems perhaps becoming so urgent that it might actually inspire Congress to make some changes?
Well, it is very difficult to predict what Congress, and particularly this Congress, will do.
Fair enough.
And I think it is interesting that, in spite of MedPAC, for years very authoritatively conveying that there are, approaching $100 billion a year of overpayments to Medicare Advantage plans, that was nowhere on the congressional agenda, which I suspect has something to do with the fact that the insurance industry is a very powerful lobby. The fact that it is argued, not necessarily correctly, that reducing payments to Medicare Advantage plans will reduce benefits. And the third ideological factor might be a preference for private solutions versus government solutions. But let me quickly identify 4 things that are likely to be unsustainable. The first of them is with the growth of Medicare Advantage, we now have, and I'm going to switch the number a little bit. As you point out, it's a little over 50% of everybody. But because people have to be in both Part A and Part B to be eligible for Medicare Advantage, actually it's over 55% of people who are eligible are in Medicare Advantage. What that means is the number of people in traditional Medicare at the county level is falling. And this goes back to work I did 3 years ago, but about almost 2/3 of counties had fewer than 5,000 people, which was the minimum risk pool size, the minimum size that is for that an ACO, an accountable care organization, has to have. So as Medicare Advantage enrollment continues to grow, it's over 70% in some counties and indeed one state. You don't have enough people left in fee-for-service to provide an adequate basis for setting rates, because the rates are based on average risk-adjusted cost in a county. And what makes that even more problematic is research has shown that there's been over 15 years a very persistent pattern of favorable selection, which means the people who remain in fee-for-service are less healthy and are more expensive. So that's an argument that says at some point, as Medicare Advantage continues to grow, it no longer becomes viable to set rates based on average fee-for-service costs at the county level. Second is, I think the coding differentials, at some point, people are going to pay attention to that. We'll hopefully both reform how risk adjustment is done to eliminate some of those incentives, but also to take away some of the unfairness in terms of both the attractiveness of Medicare Advantage versus traditional Medicare, which has not expanded its benefits, and to make the competition within Medicare Advantage fairer. The third thing is, as I mentioned, I think, and this relates in some ways to the coding, because it's associated with the risk adjustment system, is to fix favorable selection and risk adjustment. So I think those are, and the fourth is we need to improve the way quality is measured and compensated.
Well, those are great marching orders, perhaps, for policymakers looking for ways to strengthen the program and improve the experience of beneficiaries. Steve Lieberman, thank you so much for taking the time to chat with us today. I really appreciate it.
Thank you, Rob. I've enjoyed it.
To our listeners, thanks for tuning in. If you enjoyed this episode, recommend it to a friend, subscribe, and of course, tune in next week. Thanks, everyone.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about the Health Podyssey.